Greetings, I'm back with another video in my series about common sense or practical neurology, and today's topic is geared a little more towards nursing staff than the general population, and that is common causes of unrecognized headache disorders amongst inpatients. There are three I really want to discuss. The first is probably the most common, but also the most unrecognized, and that is myofascial pain. Hospital beds are not the most common, and most inpatients are very immobile. This means that patients end up with a lot of neck and back muscle strain, and this muscle strain pain is often referred to the scalp. So you'll have a patient with no headache history develop an increasingly severe headache they've never had before. Imaging is benign, non-steroidal medications don't help, opioids don't help, and then the neurologist is called in. And who may or may not find the cause. And this is because very few people know when you have a headache patient, you want to inspect the neck and back musculature, and this is done just through palpation. And more often than not, you'll find a strained muscle, usually in the neck or in the trapezius, which is the culprit, and this is addressed through physical therapy. The second is increased intracranial pressure without papilledema. So you may know pseudotumor cerebri, or what was also called benign intracranial hypertension. And this is a headache, a positional headache amongst obese patients, usually with bulging optic discs because of the pressure behind the eyes. Well, there is a variant of this condition which doesn't result in bulging discs behind the eye, otherwise known as papilledema, and that is increased intracranial pressure without papilledema. So if you have a patient, usually obese, with a chronic headache which is treatment refractory, no papilledema, then they might still warrant a lumbar puncture, and the results may surprise you, both in regards to opening pressure and response to the therapy. The last one I wanted to discuss is medication overuse headache. We've gotten pretty good about recording patients' medications at the time of admission, but one thing we tend not to do is ask how frequently they dose their abortive headache medications like Imitrex or naproxen. If people take non-steroidal drugs or Tylenol more than 15 days a month for their headaches, they run the risk for developing a medication overuse or rebound headache. Drugs like triptans or opioids, this can occur with as few as 10 days a month. In some combination drugs like Fioricet, as few as 3 to 5 days a month. So unless you ask your patients how frequently they're dosing their abortive headache medications, this will be missed. And that's unfortunate because it can be treated. And those are the three common headache disorders I wanted to discuss amongst inpatients. If you have any other questions, please don't hesitate to ask. Otherwise, I look forward to hearing from you in the future. And please, if you like these videos, please like, comment, or subscribe. Thank you very much.